Hi, my name is Cody Fafanis and you're watching the video introducing orthoptic exercises or orthoptic management of strabismus. So orthoptic exercises are used in patients who are experiencing symptoms related to an ocular motility disorder. These symptoms are usually asthenopic symptoms, so headaches and eye strain type symptoms, or diplopia. The reason that these patients are experiencing these symptoms are either due to poor convergence, they have a decompensating heterophoria, so a latent deviation that they're struggling to control, or an intermittent heterotropia, so a manifest deviation that's intermittent. Again, here we're having issues around controlling that manifest deviation. So when we prescribe orthoptic exercises, what we're aiming to do is assist the patient, obviously to become asymptomatic, but to achieve comfortable BSV. And to do this, generally we're going to look at either improving the convergence range where the poor convergence is the issue, but generally it'll translate into improved control of the deviation. And the way we get confirmation that we've improved control of the deviation, obviously symptoms are one part of that, but we look for an improvement in BVA, binocular visual acuity, and we look at that cover test result looking for rapid recovery on cover test for heterophoria, and then more difficulty in dissociating a patient with an intermittent manifest deviation. So which patients are suitable to have orthoptic exercise prescribed to? Well, firstly, you can only prescribe orthoptic exercises to a patient who has binocular functions or the potential for binocular functions. The patient must have the capacity for normal sensory and motor fusion. If they do not have this, you cannot proceed to orthoptic exercises. It is not an option for your patient. So generally, if this patient is going to have binocular functions or the potential for binocular functions, then that strabismus will have developed later on in life, generally above the age of 2. Children who have developed a strabismus under the age of 2 have usually lost that potential for binocular functions. Patients generally will have normal retinal correspondence, and the visual acuity will be equal or nearly equal between the two eyes. You always also perform orthoptic exercises with the refractive error having been addressed. And finally, the patient needs to be in good health and be motivated to undertake the orthoptic exercises. If the patient is not motivated, they won't be compliant with treatment. This also means that orthoptic exercises are difficult, if not impossible, to perform in younger children. So certainly if your child is 3 or 4, orthoptic exercises are not an option until they're older. As to at what age you can commence orthoptic treatment, that will depend on the child, their level of maturity and their level of motivation. Now you'll see here to the right, I've indicated also that orthoptic treatment tends to be most successful when you have a smaller angle deviation, so a deviation around 15 degrees 15 diopters or less, and also that you don't want to be prescribing treatment for patients who are not symptomatic. So as an example, if you find that a patient has poor convergence but doesn't have any symptoms, we don't treat the poor convergence. You're not going to have motivation. The patient's not going to be interested in improving convergence when it's not actually resulting in a symptom. Okay, finally, in prescribing orthoptic exercises, we need to be fully aware of the risks. And the greatest risk that we have in prescribing orthoptic exercises is the development of intractable diplopia. So we have to be very, very careful that patients who are selected to have orthoptic exercises do have the potential binocular functions. Because when you begin and commence orthoptic exercises, there is the risk that the patient, if they don't have binocular functions, that they will end up with intractable diplopia. So select your patients carefully and ensure that you're convinced of binocular functions being present. There are 4 main types of exercises we can prescribe to our patient, and we will tailor what's required for each of our patients depending on what we find clinically. But these include anti-suppression exercises, where we aim to remove the suppression. We have exercises that aim specifically to improve convergence, and that is from the convergence near point, jump convergence, and voluntary convergence. We have exercises that improve fusional amplitude, so fusional convergence or divergence, and then we have exercises that aim to improve relative fusional divergences, both positive and negative relative fusional divergences. In the next series of videos, we'll discuss these orthoptic exercises in more detail. Okay, that brings us to the conclusion of this video. Thank you for watching.